Hello, welcome again to Miami Community Health. I'm Dr. Anthony Gonzalez, your host. We are here again today to talk about another important health topic. July is Cleft Palate and Cleft Lip and Cleft Palate Awareness Month. Cleft lip and cleft palate. We're going to learn a little bit more about cleft lip and cleft palate, but it's something obviously that affects babies, young kids in our country and throughout the world. And when I was kind of preparing for this show, there's only one person I would think of, a friend, a colleague, Dr. Jaime Flores, to come and talk to us about cleft lip and cleft palate. As you'll learn, Dr. Flores has been doing this for a long time. He does it around the world. So let's welcome Dr. Flores. Welcome, Jaime.
Thank you. Thank you for asking me to join. I'm very excited to talk about things that I find very passionate, and I've known you for a long time, so I appreciate that invite.
No, my pleasure. So first, tell us a little bit about yourself, what you do.
So I am a board-certified plastic surgeon. I trained at one of the best places in the world, Johns Hopkins. I actually started my training in otolaryngology ENT residency, so I'm double trained, and that's really what got me into the head and neck area. In college, I went to Ecuador and I experienced firsthand as a senior in college, cleft lips and palates and how it affected people, patients in the community. It's kind of interesting. And that really was my motivation to go into some type of reconstructive surgery. I thought it was going to be ENT, and then I further got into it and found plastic surgery. And I still do it from 1994 to now, about 30 years.
Wow, incredible. And obviously, this is not only what you do as a plastic surgeon, you do a lot of other stuff. And we're going to talk about that, but just give us a little flavor of the other things you do besides the facial and the cleft lip and palates.
So I have a very unique practice. I've been practicing for now 23 years, very unique. I don't think many surgeons, at least plastic surgeons, have that specialty. I do cosmetic surgery, so I do face, nose, eyes, tummy tucks, mommy makeovers. So that's one part of my practice, especially for adults. The other part of adults, I do reconstructive surgery, either from cancer, head and neck cancer. I do a lot of breast cancer reconstructive surgery, GYN reconstruction, orthopedics, whatever is needed to cover the area and defects. So those are two different specialties in and of itself. I do a lot of microsurgery, and then I do craniofacial, probably the most difficult craniofacial surgeries that are out there, overseas and here. I also do part research, so I have my hands in every aspect of medicine.
Wow, keeps you busy for sure.
Yeah, sure.
Well, thanks for taking some time to talk to us about cleft lips and palates. So explain to our public out there that doesn't know all of this, what do they mean by the cleft lip and the cleft palate? And obviously we've probably seen people and adults, that have these scars on their lip. What is it?
So to break it down, any cleft is a separation or non-connection of tissue. So when you have a cleft, think about two mountains that are separated. That is essentially a cleft. So when you talk about a lip, one lip is off to the side. Usually one lip is normal, one side of the lip, and the other has the defect. So there are two separations. It can be unique to just the lip itself, and it can have variations of the lips. It can be very minor or a complete tear through the lip. And then that could extend into the palate. The palate can have a small defect or a long linear fissure all the way back through the uvula. So there's different variations, but essentially you're having two separations of tissues that should have been brought together at birth.
And obviously this is a problem because I remember, like, if it's really severe, if the baby's drinking, they have the milk going up into their nose, right? Because we have a separation between our mouth and our nose. So what we eat doesn't go up into our nose.
Yeah, so it's very common. You see these kids, and often these kids adapt. I tell you, they're so adaptive. So, and they learn very quickly. Like, they want milk. So they turn their head certain ways. They put their heads back. Like, they want milk going down their throat, despite half of it going out of their nose. So, but they adapt very quickly. They develop strong suction muscles, despite having, a tear or a separation in their lip. So they do have a little trouble in the beginning getting fed. They have to supplement a lot, and they have to feed more. Imagine if a kid feeds during the day 4 or 5 times. These kids are feeding 6 to 8 times just to get the same nutrition.
Wow.
So it's a little bit of a trouble for them. The teaching is key, obviously, to get them to a healthy weight so they can have the surgery. That's our biggest dilemma is you can't do surgery so quick right away after birth. They don't have enough weight to tolerate anesthesia. So we want to get them kind of fat, and it takes them a little bit.
Wow. So why does this occur?
So it's a good question. There are 3 factors I think that most of us adhere to. Number 1 is lack of prenatal care, so vitamins that we take for granted in the United States, where we go to our OBs on a consistent basis, we check our labs, making sure everything's okay. Other countries, unfortunately, don't have that same type of care. That's number 1. That's probably the majority of our cases. 2 is the inbreeding, especially amongst tribal countries that have a lot of different tribes, and especially in Central South America and remote areas in Africa and in Europe, you'll see a higher prevalence. Historically, talking about 1,000 years ago, it was much more prevalent because royal families or the kings, they inbred together. So those 2 constitute about 80% of the cases, and then unfortunately, there's about 15-20% that is sporadic, just random, happens randomly. That's what we see more in the States, is a more random pattern because we have
good vitamins, we don't have inbreeding.
Correct. That's exactly. There's still some inbreeding in the States, but not as much.
Yeah.
But clearly, those are the causes.
Wow.
Yeah. So you'll never eradicate that problem. Only because it can happen. It can happen sporadically. People think when you're born, when you're developing, that maybe the tongue is pushing up between the palate and between the lips. So when you're forming the facial structures, it's a unique transition. Our cheeks actually come this way, and our head comes down, and they have this sensory mechanism. So when the 2 lips start getting close, they start fusing. The palates are the same way, and then the head's coming down. And so if you have something obstructing, like a tongue or a large tongue pushing up, they don't get that sensory element. And that's of course what the cause is. Sometimes you'll see these cleft babies with large tongues or short mandibles, which then protrudes their tongue.
Wow. And so are these diagnosed like before birth? Or do they know this by ultrasound even before the baby's born?
Well, this day and age with the 3D ultrasounds they do with the dynamic, you can see them very early. And it's more for teaching the parent afterwards, so they're not freaked out. They know what's coming. Most of, or if not all, these kids developmentally are perfectly normal. They just have an obstructional defect. So you can start teaching the parents what to expect afterwards, how to feed them. There's certain prostheses that we use initially at birth so that the cleft doesn't get bigger. A bigger cleft, a bigger bridge that's broken down, it's harder to fix. So the more you can keep those structures closer together, the repair is much easier, much better, and long lasting.
All right, so the baby's born. The parents are freaking out. You've already told me that you're not operating on the baby when they're born. So what happens initially with these babies, and how long do you have to wait, or do these parents have to wait to have surgery?
Yeah, so they're born. Hopefully they've already gone through their pre-teachings, especially swallowing techniques, special bottles with little nibs that are specific for them. We put them in a kind of a lip prosthesis. It's basically, if you didn't have anything, you could just put tape across the baby and change the tape every day, and it would help. But we have better prostheses these days that are more comfortable. You want the baby to be at least 10 kilograms before you start operating them. The operation does not take that long. It's about 45 minutes to an hour for a lip. For a palate, it's a little longer, and you actually want to wait. So lips, usually 10 kilogram is about 3 months. So they got operated in about 3 months for the lip. The palate equally, there's some palatal prostheses you can use to prevent the whiteness. Usually the palate is operated on at the earliest 9 months to a year and a half. You want to operate on the palate because it's functional, right? You're not spilling food out through the nose. Your station tubes, which kind of drains your ears for infections and stuff, is also kind of occluded and malfunctioning because of the palate. So when kids are developing speech at that age, they'll develop speech as if they're underwater, right? Like you do that nasal thing. That's how they're listening, and that's how they're going to start speaking. So that's the time when you want to operate on them. If they're a nice, healthy kid and already starting to speak, 9 months is a good time. That surgery is a little longer. It's fraught with more complications because you're moving many structures. I mean, you're moving 3 layers of structures. You're putting them together. You keep them overnight because you have completely changed their mouth and breathing. Completely. They're used to breathing through their nose, their mouth, everything's connected. You've obstructed all that. So they stay usually a day or 2 overnight. And then we start them with just liquids for a while. And then once things are healed, you can advance them to more solid foods. And then their speech changes. They're listening to you more normal. If they go unrepaired for years, it's very difficult for you to change your speech pattern once you've already learned it.
And is it more difficult? Obviously, we're going to talk about what you've been doing around the world, but is it more difficult? You probably see those kids a little older around the world, right? Is it more difficult to repair those when they're 2-3 years old already?
So I've seen a cleft lip. My oldest cleft lip around the world in Ecuador was a 52-year-old. Imagine. He was married. I'll never forget it. Married. He worked in the farm. He worked and walked around with a handkerchief all the time. Great guy. And older with much more tissue was easy to repair. I mean, it was easy.
It's big.
And I'll never forget his wife, when we fixed him and showed her the picture, she goes, "He looks beautiful. Now he's going to leave me."
That was great.
Imagine that. So, but kids, yeah, it's, the lips are easy to repair as you get older because you have more tissue.
Okay.
I mean, that's clearly an easy factor. The palates get a little harder because it keeps expanding. And so you have to really be mindful of your first surgery with the palate. If there's too much tension, you have destroyed the tissue, it's going to fall apart. And then you get a fistula. They're much harder to repair. So I see when I do my mission trips, a lot of fistula because things have broken down.
Because somebody has tried to repair it or has repaired it, maybe not done a great repair.
So much harder when you're going to the second, third surgery. Much harder. The surgery requires more flaps from other locations to bring into the area. In the States, the same thing. I get referred to me cases that are super difficult where we have to do even microvascular free flap transfers because they've exhausted all their options internally.
Wow. So talk to us very, superficially about what these operations are about. I mean, it's not as easy as just sewing the lip together, right? I mean,
no.
Right. And of course the palate, and explain to us, obviously there's bone in there, there's cartilage, right? There's a lot of tissues in that palate. Put your tongue up there and you can feel your palate, for our viewers, that's the palate up there. So what is that operation like?
The lips are probably easier to explain. So the lip, you have 3 components. You have skin, and the skin has all these specific landmarks that we have to put back together, right? You have the Cupid's bow, you have the philtrum, the columella. So essentially, if you break it down as if I were to call it 2 procedures, it's rotation and advancement. And it's very basic, but you're operating one, which is not common for surgeons. You're operating upside down. So essentially, the head is here and the feet are away from you. So you're looking at things almost backwards, right? That's just how the person who created some of the best techniques, that's how he saw the rotation. So essentially, one side is short, if I want to make it very basic, one side is short and the other one is normal. You want to basically open the short side right? Making a slit, however you want to open it, and you want to advance things into that area. So you create evenness on both sides. That's essentially. The other components are the muscles are not going all the way across. They're kind of going up. So they're misplaced. So
you got to reorganize the muscles.
Reorganize the muscles have to be brought down and brought across. So you're taking care of the skin components, the aesthetic, which everyone sees. Then you got to take care of the muscle, because if you don't, it's called a whistle deformity. When you try to do a whistle, there's no continuity. Your lips don't come together. So that's a very common also complication when they repair the muscle, and if it rips, they're not together. So you do the skin, do the muscle, and then lastly, it's the internal layer, the mucosa. So you have to repair them in several layers, and you actually start with the bottom layer, the mouth. Do the mucosa, and the mucosa stretches. It's very easy to close that layer. Muscles, not as hard, and then putting the skin components so it doesn't look deformed on the outside. Some of the complications that you can see with cleft lips are a shortened lip, so they didn't release enough. So we do all these fine measurements. There's about 32 measurements that we do for clefts, with a fine little toothpick marking each one so you can line them up. And you have to account for scar contracture. So you know the scar is going to contract. So if you measure everything equally, you got to add that 1 little millimeter for scar contracture. I learned from some of the best in the world. I learned from one of the older craniofacial surgeons at Hopkins, and then the new chair at Hopkins now trained in Toronto kids. So I got to train with 2 really good people. And it's a fun surgery. It is totally fun.
Well, obviously, in what you do,
it's like a puzzle.
Well, and that's also the way you impact those kids and their families. I mean, as a father, right? You do anything for my kid, it's like doing 3.
Life-changing.
It's life-changing. It's like you're triplicating what you do for me because it's doing something for our kid.
And the great thing is it's free. Like I do these things
of
overseas.
Course, yeah.
It's gratifying. These moms, they can't get care. No one's going to do them, and not everybody in the world can do these surgeries. So it's specifically, someone who does it all the time.
And taking your time to do that, man, that's a blessing.
Small sutures, I have these big old mitts that my mom calls, and it's very precise surgery. Cleft palate's another different animal. You have so many components to deal with. Again, you're upside down. You're opening the mouth. And it's several segments of surgeries. You open the mouth, so you're going to compress the tongue. You can only compress the tongue for a certain amount of minutes. So it's like compress the tongue, inject local. Put the tongue back down, let the local work. Especially you want it to work because the mouth is very vascular. Open it back up, make your cuts. So again, you have 3 layers of closure. You have mucosa of the mouth, then you have the muscles of the palate. Remember, they're going to be running up into the cleft, and you got to put them across. And then you got the nasal mucosa. So there's 3 layers. You want to reorient that muscle because when they work, they pull and they open the eustachian tube.
Oh my God.
So it's several components. So you open, you make one cut, let it down. Open, make another cut, elevate the flap. Usually you have to elevate the tissue off the hard palate. You have to kind of do this and into the center. We leave raw areas inside the palate, so like relaxing incision, what we call in surgery, and those heal. Within a week, you'll never know we even made an incision.
Wow.
But they're raw, so they can bleed. There's a neurovascular bundle. Like, it's much more involved, the palate. You want to put everything back in its layer, and you don't want to, then you have everything lined up. What you don't want to do is shorten the palate, because the palate is what prevents us from food going through our nose. Palate closes off. But if it's short, you fix the cleft, but now you're still leaking food back
around,
in.
Ray.
So all those components are in your head as you're putting this together in this, 1-year-old or 2-year-old, and then you got to make sure there's not bleeding. Make sure that he doesn't swallow and aspirate. There's so many things that are involved with the palate, and the surgery a little bit longer. When things break down, they really go bad.
Yeah, you said that, fistulas and its problems.
Yeah.
Wow.
Correct.
So you've been doing this for a long time, and as like someone like me who's done missionary work for a long time, and you go back and you see these people. Tell me about some of those kids that were babies, now they're kids, and you get to see them, huh? How satisfying is that?
That's the blessing. I try to go back to the same area. So I've seen kids that I've done at 1 and 2 years old, and now they're 18.
Wow.
Impressive. And I personally, I look at whatever my result as a good and a bad. Like, how good did I do? How good does it look? And then is there anything that I could do better?
Right.
You know, but the biggest, you know, reward are the parents coming to me and giving me a hug. I mean, I've gotten gifts that range from specialized postcards to mangoes to live chickens.
I was just going to say chickens.
Live chickens for sure. I'm like, no, I think you need this more than me, you know? But that's the reward.
Yeah.
And then especially their functionality afterwards, that's
changed the kid's life for forever. So what do we want our community to know about cleft lips and cleft palates? What is it that we need to create awareness about? Is there something like early intervention? Don't be scared. What is it that, you know, there is a solution? Take your multivitamins. I don't know. What do we have to create awareness about?
I think there's probably a multitude of things that I would probably want people to know, right? Number one, it happens. No one's fault, you know. 2, the kids are normal. Kids are, I mean, smart. These kids, the kids I've seen 10, 20 years later, smart. Some of them want to go into surgery. Like, how great is that? You change their lives, they're going to surgery. So they're smart. 3, there is resolution to the problem, 100%. Especially in the States, we have much more access to better medical care. 4 is, you know, there is a cost to this, right? We need to help our hospitals, local hospitals, like Miami Children's, who dedicates themselves, and there's a lot of us, like myself. I dedicate my time free to Miami Children's, but there is costs that are going to accrue. So to help foundations that are in need of care, and lastly, you know, you'll see somebody, you don't have to stare at their scar, right? I think that's the biggest thing that people like, staring at scars. Scars can be fixed. Usually there will be some type of revision. I don't care how good you are. Usually we start revising things usually later in life when you have more tissue and they look perfectly normal. There's many of actors and actresses who've had clefts and you can't even tell, you know? So it's not a scary thing. There's a good fix. And we need to help our community and parents and hospitals, you know, to help them achieve their goals.
Wow. And so obviously this is multiple different areas you've been going to. There's Operation Smile. Tell us about some of those other organizations and some of those groups that you participate with.
So I have my own foundation. It's called the Healing Hands Foundation. And we're very dynamic. We do more than just plastic surgery, cleft lips and palates. We do pediatric surgery and general surgery. But there's other organizations that specifically focus on cleft lips and palates. They specifically have funds only for their cases. Smile Train is phenomenal. I love Smile Train because they fully support the physician traveling. They give them a stipend. They go to their airfare and hotel and food. It's not like it's we get paid to do it. And they have a lot of support. A good chunk of their money, every dollar, I want to say at least 80%, goes to the mission and 20% administrative, where some other organizations aren't, you know, situated that way. At least they're there. Unfortunately, overseas, not a lot of surgeons are either skilled or want to do in country operations. So at least we're getting something done. I think we need more training. In that aspect, I think we're losing some of the specific training, maybe just like in general surgery where, you know, 20 years ago, 30 years, the general surgeon did everything.
Yeah.
Head to toe. There was nothing you couldn't do. I think we're losing some of that. And hence, some of the people throughout the world aren't getting, you know,
the care they need.
Unfortunately, it's not their fault that they can't get their care.
And Smile Train, and I know Operation Smile, these are worldwide? Worldwide programs.
Yeah, they are, they're based here in the States, and they're what, if you want to get involved. I mean, there's other organizations who will love to have volunteers. I go with other organizations outside of my own that invite me if I have free time. I'll definitely go. And, I bring all my instruments. I bring every supply that's needed, so not to abuse the supplies from the local hospitals.
Wow, great things you're doing. Well, it's beside everything else you do in your everyday practice. Of course, I remember you on that microscope, free flaps, right? So, tell us about some of the other things that you do besides that.
Yeah, here in state, I still do kind of everything. My microsurgical practice is thriving. In Miami, there's not a lot of us that do microsurgery, and unfortunately, some people need it. So I do a lot of breast reconstruction. I created about 7 years ago a whole movement to restore sensation to breast cancer patients after mastectomy, and that's going phenomenally. Where historically most women would lose sensation. Now we're restoring it 95%.
Wow!
So that's a new and explosive movement. I do my research with FIU students, which is, I think, a nice soft passion of mine. It helps them get into med school, and it helps keep me academically oriented. I think we have to stay attuned to what's going on in medicine. And
continue to contribute. Like, you showing the benefit of those sensation after breast cancer reconstruction, you could teach other people, other surgeons around the world and teach them what you're doing.
Yeah, the practice is great. I love Miami. Miami's a great central location, especially if you want to travel throughout these different countries that need care. It's very accessible. And I'm expanding. I think that the next 10 years of my practice is going to be more expanding my skills to South and Central America.
Wow. Well, I think you're doing what we decided to do as a doctor, help others. Whether you're helping the kids out in Ecuador or some other part of the world with their cleft lip and palate, whether you're helping the cancer patients here, or you're even helping an FIU student who wants to get into med school, you're helping. So, Jaime,
I'm trying.
Thank you, man. Thank you for coming.
Thank you, man.
Thank you for everything you do.
It was a pleasure.
Thank you for educating our community about cleft lips and cleft palates. Don't be scared if you have a cleft lip or cleft palate, if your child has one, or if a family member. Get care. There's great care here in Miami, great care in the U.S. And as I always tell you, take care of yourself and your family. Dr. Anthony Gonzalez for Miami Community